Hi, everyone. This is Podcast for Patients with the Aplastic Anemia and MDS International Foundation, and I'm Alice Hauk, Senior Director of Patient and Professional Programs. Our podcast series is brought to you thanks to generous support from patients, families, and caregivers like you and our corporate sponsors. Thanks to everyone for supporting this series. Today, we're talking about the U.S. Food and Drug Administration expanded access approval of luspatercept or Reblozyl with Dr. Guillermo Garcia Manero, Chief of the Section of MDS in the Department of Leukemia at MD Anderson Cancer Center in Houston, and a member of our AAMD-SIF Medical Advisory Board. Welcome, Dr. Garcia Manero.
Welcome. Thank you very much.
Reblozyl or luspatercept recently received expanded access approval from the FDA. What does that mean?
Well, actually, I don't know what expanded access means per se, because I think that what happened is a little bit more than that. So Reblozyl, that I like to refer to as luspatercept, that is the scientific name of the medication, was approved around 2 years ago for patients with a specific type of myelodysplastic syndrome called ring sideroblastic anemia that were not benefiting or were not candidates for an erythroid stimulating agent drug like, let's say, epoetin alpha. And that was the first label. And that study was called the Medalist trial, gave us the first approval of this drug. And then we saw a couple of things. First, that overall the drug is well tolerated. And second, that patients with less transfusion needs did better. So the study called the Commands trial was designed, and that was a study, phase 3 randomized study upfront for any patient with low-risk MDS transfusion dependent, comparing this new drug luspatercept or Reblozyl to the standard of care with epoetin alpha. And the study that was recently published in one of the top journals in the world called The Lancet and presented at the American Society of Clinical Oncology meeting and the European Hematology Association meeting, the results showed that this is really effective therapy when compared to the standard of care. So with that, then, this drug now has an approval for patients with low-risk MDS that are transfusion dependent of any phenotype upfront as first-line therapy. And so, yes, it's expanded, but it's not like they decided to expand the access. It's just like there was a very important phase 3 randomized study upfront for low-risk MDS patients with anemia needing transfusions where this drug was shown to be superior to the standard of care.
And what can patients expect when starting treatment with luspatercept?
Well, this is very important news, I think, because we have been using these drugs like epoetin alpha, erythropoietin for decades in the United States without actually a formal approval. So these drugs actually were never really tested in phase 3 trials, but it was our workhorse for many, many years. And the reality is that they are good drugs and they have helped our patients for a long time. But the response rate probably is around top 30% or so, and very few people will have long-lasting responses with these agents. And of course, the drugs were safe. So we needed something better. But nobody had done a frontline randomized study like this. So this is actually very exciting. And the data clearly shows that this drug is better for 2 reasons. First, the response rate was double, was 60% or so versus 30%. So I think the patients should expect a greater response rate than with the standard growth factor. But more important to me is perhaps the fact that the duration of response is significantly longer. So in the study, the duration of response was 126 weeks versus around 70-something weeks for the epoetin alpha. So it's almost like a year longer in response. And the response was defined by an increment in hemoglobin level of 1.5 grams plus transfusion dependency that was around 12 to 16 weeks in the first 24-week period. So very significant amount of transfusion dependency, increase in hemoglobin. And again, when compared to a standard of care, significant increase rate of response and duration of response. So hopefully when we apply this into the real world, we will see the same kind of results where you will have a greater response lasting for a longer period of time. That was basically the objective of the study. And this, we hope that in time will translate into better quality of life, and God knows, maybe some other improvements in the prognosis of this disease, but that we don't know yet.
And what are the common side effects that patients may experience on luspatercept?
Yeah, so this drug is a subcutaneous injection. It's given every 3 weeks. It's approved already, as we mentioned a couple of years ago, for specific type of MDS and also for non-MDS condition, non-thalassemia. That is not a type of leukemia or neoplastic process. So you will think that the FDA, based on that, approved this drug both in first and second line because it has an excellent safety profile. This drug is not chemotherapy. It should really not change the blood counts of our patients, meaning making them worse. But a fraction of patients may develop fatigue, and that fatigue sometimes is actually seen in patients that have a good response to the medication. We don't understand that very well, but occasionally, not very frequently, but occasionally the patient may experience some fatigue that, it could be troublesome for the patient.
Is there anything else patients should know about luspatercept or how they should speak with their doctor about possibly considering that as a treatment?
Yeah, so there are two issues. First, going back to the toxicity question, when we compare the toxicity profile of luspatercept versus the standard growth factor, there were no significant differences. So this is, I think, reassuring. I think because MDS is not that frequent disorder, it is possible that a lot of the physicians in the community may not be familiar yet with the drug or with the fact that this drug now is approved for first-line indication. And actually, sometimes the patients are the ones reaching to the doctors in the community saying, there's this compound. Do you think I'm a good candidate or not? The second issue with this medication is because it can be quite potent, it can increase the hemoglobin level significantly up. There are some boundaries in terms of basically how to dose the medication. And it was based on the original studies and FDA mandates. So there's basically like a titration scale in terms of how we do this. So you start at a dose of 1 milligram per kilo, and then you do a couple of doses, basically 6 weeks. And if there is no response, you can increase the dose to 1.33. And then you could do that again to a dose of 1.75. I think most doctors and patients are familiar with this, but occasionally I see patients that are still at a low dose, not really responding. And this is something to consider. Sometimes also what you have is the patient has a great response at, let's say, 1 milligram per kilo. And then, a few months later, you start losing a little bit this response. You could increase the dose at that time. So you have like basically 2 steps up with the dose of the medication.
Thank you. Are there other developments in MDS that you foresee in addition to this important approval, which is the first in many years for low-risk MDS? Are there other things on the horizon or other adjustments that patients might be seeing in the future?
I think we're seeing a gradual push to new therapies in lower-risk MDS. So one concept is this idea of starting treatment early, meaning in patients that are transfusion independent. There was some nice data from Europe showing, for instance, in del(5q) minus MDS patients that they start low-dose lenalidomide early having really good outcomes. So there's something that is starting to take some traction. There is new data with the hypomethylating agents, particularly the new oral hypomethylating agents, drugs like this oral decitabine cedazuridine, with nice activity in some group of patients with low-risk MDS. And then, not yet with us, but maybe at some point soon, we heard about a new drug called imetelstat that could be a potential second-line drug for patients that fail ESA, like erythropoietin alpha, or maybe luspatercept. We will know next summer whether this drug is approved or not by the FDA. And actually, the EHA meeting last summer, or I should say this past summer, we saw already data from what we call second-generation drugs like luspatercept. There was a drug called KER-050 with some nice response also. So that's interesting that we'll have also kind of second-generation drugs like that. And I can tell you that at MD Anderson in the phase 1 program, we have like around 5 or 6 new compounds that target different angles of low-risk MDS. It's early, but it's very exciting to have these kind of drugs for this patient population, where in the past, actually, we didn't really have access to any significant, studies or new entities for a group of patients with low-risk disease. So it's actually quite exciting right now for clinical research in low-risk MDS, and the fact that we have big important approval with Reblozyl, maybe good drugs coming in the pipeline for second line, the imetelstat, and some of these other phase 1-2 trials that are ongoing. So I think it's really good times for low-risk MDS.
Thank you. And one final question. These drugs, Reblozyl, luspatercept, and the others that you mentioned, are all being developed through patients participating in clinical trials. Can you talk about the importance of patients considering clinical trials if they are eligible?
First of all, we should be grateful to the patients for agreeing to participate on those studies. They are cumbersome and it's a huge effort for them. So we are very grateful to the patients and their families for this. But the reality is there cannot be progress in this disease unless we develop these drugs. In other words, we cannot have these new agents unless the physicians design and conduct those studies and the patients and the families agree to do this. Of course, it has to be something that is safe and logical, and every patient is different, so we need to target those studies for specific clinical situations. But I think that for a disease that is so heterogeneous as MDS, that's probably one of the main issues. We're so slow developing drugs, and the fact that the disease affects a little bit older population, sometimes not in the best condition to travel to an academic center or some place where they can do this kind of research, that may be a little bit of hesitation in terms of participating on those trials, that I totally understand. But if you think about, for instance, the effort that the patients that were part of the COMMANDS trial or the MEDALIST trial did, and realizing that this was a randomized study where some of the patients actually got into the control, there was not placebo, it was in this case erythropoietin alpha, but the fact that then this drug now is approved worldwide, I hope this is going to have for all our patients with low-risk MDS. It tells you how important it is to be on those studies. So we should be thankful to the patients, but they need to recognize also how important it is to consider those studies so we can move the field and provide them with the drugs that they deserve for their betterment.
Thank you, Dr. Garcia Manero, for sharing your time and expertise with all of us. You can find out more about MDS treatments on our website at www.aamds.org, by following us on Facebook, Instagram, and Twitter, or by calling our helpline at 800-747-2820. This concludes our program.